Hello, everyone, and welcome back. We now have Q&A time with our speakers, and I'm going to kick it off straight away with a question for Dr. Wang. How would you recommend that people find the resources for integrative therapy for their EDS?
Yes, a great way to start is checking in with your primary care physician. Oftentimes, they have great resources in your community. That's a great way. And then a lot of the patient support groups have resources as well.
Thank you. Question for Dr. Tishler. We've had quite a few questions come in on how to deal with nausea before and during cannabis therapy. What would you recommend? I think you might be on mute, Dr. Tishler.
Yep. All right. I apologize. So I'm a little confused by the question. Is the implication that the nausea is caused by cannabis therapy, which I think would be very unusual. So I think I will, in absence of clarification, answer the question as the use of cannabis for nausea, which is something that we do fairly commonly. And if people are experiencing nausea, particularly that interrupts activities like eating, then what I would typically recommend is a low dose of cannabis vaporized flower, typically, 10 to 20 minutes before an anticipated meal. And I think it's important to understand that in that case, inhalation is a better approach. And that one wants to do that by vaporizing flower because that's the safest approach to inhalation.
Thank you. And I'll see if we get any more clarity on that question, but hopefully that answered it. Thank you. Dr. Burling, what types of EDS and HSD symptoms does prolotherapy help with?
We found that it helps with people who have dislocating joints, people who have chronic pain, people with chronic neck pain, back pain. We've also had help with people with craniocervical instability, the shoulders, hips, knees, ankle instability. All these areas we have found that it helps significantly right through age groups. And it doesn't matter how old the injury has been either. So we've had people who have waited 50 years from their initial injury before they get seen at the clinic or before they found someone who can help them. And they've still had an excellent response. So we've found it helps multiple areas.
Thank you. And Dr. Wang, someone's pain management doctor has recommended dry needling. Are there any contraindications or EDS specific risks you should be aware of when it comes to dry needling?
That's a complex question. So first, I would say, you have to trust your provider. So a lot of times, if you're in the US, the United States, insurance-based practices, you do have to go through a protocol. And if you must go through that protocol, then trust your physician to make the right call for you. Certainly, if we are looking at fascial balances and there is an area that needs to be strengthened, and then there is an area that needs to be quote unquote loosened or relaxed, then a selective use of dry needling, of trigger points, et cetera, myofascial release would be appropriate. But the first step is definitely to trust your provider, because definitely there are contraindications in general. If it's done indiscriminately, there are case reports of worsening of cranial cervical issues.
Thank you. Dr. Tishler, do you know if cannabis will affect daily life? For example, someone at university training to be a nurse, would taking medical cannabis affect this? And you're on mute. Sorry.
Sorry, there's enough background noise that I want to go back on mute between
No problem.
So yes, I think we actually have a pretty good handle on this. And the short answer is yes, it can be a concern. There have been a number of studies. Sort of the most famous one is called the Maastricht study, which is named after the city in Holland where this was done at the university. And we've learned from that school performance and work performance will degrade if cannabis is used during the performance of those activities. And so when we think about using cannabis therapeutically, we have to keep those issues in mind. And if, for example, in that nursing student example, that person was having anxiety or insomnia, then we would be using the cannabis in the evening. So it's, after study, et cetera, then that's perfectly fine. And we would not expect to see any decrement in performance, but we would not recommend it for daytime use. If, on the other hand, that nursing student were having issues with appetite, weight loss, and pain, then we might have to consider some daytime use. And it really becomes a very individualized sort of risk-benefit discussion that, to Dr. Wang's point, you really need to know who you're talking to and be able to trust the provider to guide you through those decision points. But it is something that requires negotiation and seeing how these things fit into the individual's life.
Thank you. Dr. Burling, is prolotherapy a successful option for those who have already had multiple surgeries to the affected area?
That's a difficult question to answer, and it depends on the type of surgery that's been had and if there is significant surgical pain following treatments as well. I do note that there are times when a person comes to me with back pain and they don't have to have EDS, but they've had 3, 5, or 10 surgeries, and I find that I can't help them at all because of the surgical pain. So sometimes it's yes and sometimes it's no, but it really depends on what surgery has been had. I still think that people can have dislocating joints helped, but not necessarily pain helped following some types of surgery. So that's a guarded answer, but it really does depend on what's happened.
Thank you. Question for Dr. Wang. Does this mean that mast cell issues could cause an aggravated pain response as seen in aggravated pain syndromes such as CRPS, or am I reading too much into that?
That's absolutely correct. And I think all the panelists will agree since we meet every month and we have similar discussions. Definitely in that fascial tissue, you have that integration, that crosstalk between that nervous system, that immune response. And so it goes both ways. If you're stressed out, then the mast cell gets set off, and then those C fibers are going to be irritated. So absolutely, you're not reading too much in there.
Thank you. Dr. Tishler, what are the recommended milligrams of CBD and or THC if they were to be used for EDS-related pain?
So first, let me start by saying that I think that the data for CBD are terrible in human beings. And so that one is one that I think most people don't get as much benefit as they might anticipate from sort of everything that's been said in the popular press. And so I don't recommend it. And as we go along, we're hopefully going to get more and more data on CBD, which will be useful. Some of the more data that we've gotten over the last year or so has actually been pretty unfortunate, showing not only significant interactions with other medications that EDS patients might be on, but also some direct liver toxicity at higher doses. So I think that CBD at the moment seems to me to be largely the emperor's new clothes. I think ultimately we'll find that it will be useful for a number of things, but it's going to need to be done in a fairly careful setting and possibly even with some subsequent blood testing on a regular basis. If we're thinking about EDS pain, though, that's something where I would turn to our friend THC. And the goal with cannabis medicine, just like every other kind of medicine, is to find the least amount that we need in order to get the benefit and to minimize the side effects. And I think that many people listening in would have some concern about THC and its intoxication. And I think that we have to recognize that that's the major side effect of cannabis medicine. And we have to treat it as such and acknowledge that we'll always have some, but our goal is to minimize that. And so to get to the answer of the question, that depends a bit on the individual, but I can say that most of my patients are getting benefit from somewhere between 5 to 15 milligrams of THC on average. A few a little bit lower than that and a few a little bit higher than that. But really, that's the range, 5 to 15 milligrams. And then the other thing that makes cannabis interesting is that it behaves differently depending on how we take it. So if we're talking about chronic pain that we see with EDS folk, then something that is long acting like an edible, like a little tiny gummy, would be preferable to any form of inhalation, which has some additional risks and complications to pain management associated with it.
Thank you. Dr. Burling, when we think about the wound healing capacity in people with EDS and HSD, what do you think about the efficacy of prototherapy and other regenerative injections? Does that affect the healing time?
It does to a little degree. So people with EDS can be a little slower to heal than people without. My clinic was dealing with treating soft tissue injuries long before I had an interest in EDS. And we have seen that it can take more injections in someone with EDS than someone without to stabilize it. However, we still find that 80 to 90% of patients need only one injection per injured spot in order to stabilize or treat it, which is really good news for people with EDS. So it's not a big difference, it's only a small difference. We do have some patients who take more than the average, as you saw on the cumulative probability graph, where the range was out to 22 to stabilize a joint. However, as was noted in that patient, when she had a fresh injury to the same joint, it only took 7 to restabilize it because there was that much more tissue there already. So it took a new injury for it to go wrong again, but with that much more tissue present, it took much less to restabilize. So we know that it only takes a little more than someone without EDS to help stabilize tissues in people with EDS. And that's really good news for people with EDS, that these are very treatable. We have found that it can take a little longer for the pain to settle in some people with EDS. So some can take more than a week and occasionally up to 3 weeks.
Thank you. Question for Dr. Wang. Do you have any experience of things like acupressure mats, percussion guns, massages, etc., being helpful for general aches with EDS?
Yes, and the caution I would take. So first, yes, and they're wonderful tools. And they can be very empowering. And I send patients home with it. If they have these tools, they'll ask me how to use them specifically. And so that's the other point, is that I tell my resident physicians all the time, it's not the tool, it's the application of the tool. When, how, where are you going to apply that tool? That's the art of medicine. So yes, I've had patients destabilize themselves many times, even without EDS. So I would say bring those tools in to your practitioner, whoever it might be, who's skilled in these modalities, and have them show you how to use them properly.
Thank you. Dr. Tishler, are there any other, hard to read. What kind of cannabis, do you recommend for people who have gotten anxious when trying cannabis in the past, or patients who are already struggling with anxiety?
That's a very common question. Thank you. I don't think that the type of cannabis is particularly relevant. I think that there's...
Oh, we seem to have lost you. There you are. You're back. We can see you, but we can't hear you.
You guys hear me?
Yes, we can now.
Okay, much better. Sorry about that. So there are over 7,000 different types of cannabis listed on various websites that keep track of this, like Leafly. And I think that it's very much in the interest of the cannabis industry to put forward this idea that all these strains are different and lead to different outcomes for patients. And there's no question in my mind that there are differences that can amount to preferences, but when we're looking at different, really not seen any. And in my practice, I tend to try to be fairly agnostic to the specific.
And we've lost Dr. Tishler there, so we'll move on. Hopefully he can come back and answer that later. So a question to Dr. Burling. Is prolotherapy a successful option for those who have already had multiple surgeries? I may have asked that one. Have I asked that one to you?
I've asked that one already.
Sorry. Our Q&A team, we need to get deleting those questions asked, please, if we can. And I touched briefly on the other forms of regenerative injections, but wanted to know injections such as PRP, PRGF, and stem cell prolotherapy. Do you think that they could also help EDS patients?
Absolutely, and yes, we have seen that already. And it's a technique, is about where it's applied is important. And as I've noted, that people who've had PRP or stem cell treatments, we don't actually have that much stem cell treatment in New Zealand yet, apart from into joint capsules, and it has been effective in joint capsules. In soft tissue, when someone's had PRP injections, I have not had to retreat those areas. I've only had to treat the adjacent areas that were not yet treated. And that's a really important thing to remember, that you treat the tennis elbow and there are adjacent areas that may still be present causing pain, and you have to treat those to get rid of the pain. But I have not had to retreat areas that have already had PRP unless the patient has a new injury. And I noted in the question that was put up before that we don't have to retreat areas in most people unless there is a new injury. So these can be long-term benefits. And as you've seen, we've seen these results now out to 6 years in stopping joints dislocating in a recheck of the patients from that same cohort when we went back and looked this year at the same patients.
Thank you. Dr. Wang, have you seen different results depending on the type of EDS?
Absolutely. So it's important to note that hypermobile EDS is one of the most common type that we see. The others with known genetic variants are rarer. So it's difficult to compare if you want to look at gross numbers. But absolutely, the presentation of an hypermobile EDS patient will be very different from a classical EDS. The pathophysiology that we believe is also different. So how we approach these patients will be very different. And it also is worth noting how we treat every EDS patient will be different, because their symptom clusters will differ based on their lifestyle, their genetics, and who they are as a unique individual. So all of these things play a big role.
Thank you. Dr. Tishler, I think you're back with us.
I hope so.
Yes. So if you could just conclude what you were saying there about anxiety and taking cannabis, please.
Right. So, thank you. So I was basically making the point that I don't think that strains are terribly relevant, and that dose and timing are the key elements. I have many, possibly hundreds of patients who've come to me and said, well, you know, I need this for fill in the blank, anxiety, pain control, whatever, but I tried it, or I tried it back in college and I had a terrible paranoid reaction. And of course, you know, if you tried it in a recreational setting, particularly years ago in college or something like that, nobody's paying attention to dose. It's certainly not a situation that's conducive to relaxation and symptom management. And so when we go at this again, using a much more precise and much lower dose, generally I find problems don't occur. So if somebody's experiencing that, I'd be happy to talk with them about how they're approaching things and try to work out a regimen that would be more effective, as well as not provoke that anxiety.
Thank you. Dr. Burling, I'm going to read from mine because I'm not sure if things have been updated. What is the effectiveness of prolotherapy for neck instability or subluxations? Why might providers be afraid of injecting on the neck?
I'm going to answer the second part first. The neck has a lot of areas around it which are tiger territory, to put it bluntly. So you've got nerves, arteries, and veins that are really important to dodge. So some people may be afraid of injecting around those areas, especially if they're not aware of or not comfortable with avoiding the target territory or knowing how to approach safely. However, the neck area can be safely treated with some exceptions. So if someone has a Chiari malformation, and we avoid it. If someone's had surgery, we have to really know their anatomy, and we'll get an MRI scan so that we can approach things safely. When releasing stuck joints in the neck or manipulation, the first rule of manipulation is knowing when not to manipulate. And those safety issues are incredibly important about knowing when you can treat and when you can't treat. Speaking also about safety in treating, we don't treat with someone with an active infection. If someone has a mast cell flare, we'll wait until they're over their flare before we treat as well. Those are general contraindications to treating, but in the neck, you just have to know the anatomy incredibly well and know where you can put a needle safely and how you can approach it safely in order to avoid serious side effects. So you do need a good knowledge of anatomy and a good understanding of what you're treating and where when you're approaching a neck. Having said that, we've safely treated hundreds of people with neck issues at our clinic, and as you've heard, other people around the world are now starting to do the same thing. And the young lady I presented had her craniocervical instability stabilized with PRP in America with the same treatment, following the same protocols.
Brilliant, thank you. Dr. Wang, could you please speak to music in spiritual breathing practices? People mention yoga very frequently. Would a musical instrument or singing provide the same benefits?
Yes, and in patients, again, patient specific. If singing comes naturally to you, it is part of the profession, then definitely. If it's part of the yoga practice or something you like to bring into the yoga practice, definitely. The important part is to note that it's not for everyone. So if it works for one person, it may not work for another person. It really speaks to what connects with you at a deep spiritual level. And definitely there are scientific studies, there's medical studies that show its positive benefit on that parasympathetic, sympathetic nervous system. I add it in when it's part of a patient's routine, or when they tell me in the history they used to sing and it brought them so much joy and they no longer sing, or they love to sing in the shower. And I say, well, turn that up, sing all day long out of the shower as well.
Love that. Thank you. Dr. Tishler, is there any information on the new Delta 8 or THCO? I'm interested if these are as effective or if there are many risks.
So Delta 8 THC has really hit the world hard in the last few months. And the largest reason around that is that following the Farm Bill of 2018, which legalized CBD, people have figured out how to manufacture D8 from CBD. While CBD is legal now under that law, the derivatives, and particularly the THC derivatives, are not legal, despite what people seem to be thinking. we have very little data on D8 by itself. As people may be aware, D9 is the predominant THC in normal cannabis, and there is a small amount of D8 in there, but it's tiny by comparison, and there have been no studies that have looked specifically at D8 in human beings. So I think our sense is that it is less efficacious, it's less effective than D9. And while it may be slightly less intoxicating, it's really a dose-related phenomenon, meaning if you used enough D8 to get the benefits that you would get from D9, it would probably be similarly intoxicating. But the other thing, and somebody in that question was embedded about safety, these things are, as I mentioned, really illegal, and therefore there are no safety protocols on the manufacturing and testing. So at this point, if we were to extrapolate from the CBD side of things, where this stuff is now being manufactured, we found all kinds of contaminants ranging from benzodiazepines and opioids to pesticides and heavy metals in garden variety CBD products. So it's fair to assume that those sorts of things are likely to be present in those D8 products also. So the short answer is I don't think D8 provides us much benefit. It's not legal, and it's probably contaminated with things that we don't want. So my sense is that that's just not ready for prime time.
Thank you. Dr. Burling, prototherapy is often not covered and can be very expensive, and also not often offered out to the patients worldwide. Can you speak to where the research is at the moment and the timeline for it becoming a more accepted treatment option?
That's a really interesting question. The timeline is a difficult one. Certainly in Europe, where a lot of the studies have been done in people without EDS, there are quite a few people there who have published on it, including the prospective randomized placebo-controlled double-blind studies have come more from Europe than from America. I know that there are people in America who use this, especially PRP. Dextrose is still the most common used internationally. And I think because it's the weaker one, then there are reports of that in the Cochrane Review, which is considered the gold standard for evidence-based medicine. And we haven't got reports yet in Cochrane Review on the stronger agents. However, PRP has sufficient information to have been mentioned at least a couple of times in the Cochrane Review. As for people around the world doing this, I would love to see more people doing this and hope that meetings such as this can stimulate others to begin to try it who weren't previously doing it. And as we get more collaboration happening, we can then get multi-center prospective RCTs or randomized controlled trials going that can then confirm what we've seen in the retrospective studies and in the studies in prospective studies in non-EDS patients. So we're hoping that more people will do this, and I've had people contact me from around the world who are interested in following the protocols and who have started and getting similar results on individual levels. So we're hoping that this will continue to spread and more people will do this. But at the moment, it is fairly difficult to find people. However, I do know that the Ehlers-Danlos.com Society has got names of some people already, which is really useful.
Thank you. Dr. Wang, what about those who are hurt severely by massages and when aquatherapy leaves people feeling weaker once they come out of the water? What would you recommend?
It depends on the person specifically. So definitely there are different types of massages. And I would question, what type of massage did you have? There are really gentle osteopathic treatments that really calm the nervous system, which may or may not fall into a massage category. It's difficult to categorize many of these touch interventions that we have. In Europe, I believe we call that continuous touch therapy. Out here, we might call it cranial sacral. So it really depends on the type of quote unquote massage. They're all not all made equal. And again, we go back to that trust component. Do you trust your practitioner to know what she or he is doing? The other component to the aqua therapy is, oh yes, I've had tons of patients who don't do well with aqua therapy. Right? When we make recommendations, we can only make blanket recommendations for the population as a whole, but it's important to remember, as always, you are a unique individual, and that program has to be tailored to your needs. And I know Jeannie DeBon specializes a lot in that movement piece. And that is an example of a practitioner who can really work with you one-on-one, individualized, tailored program. And that's part of the recommendations too, is yes, there are movement therapies like getting into the water, but there's also very tailored programs that are crucial, especially if you're having so much problems that you can't even get into the water. That resistance is too much for your body.
Thank you. Dr. Tishler still with us? Yes, there he is. What do you have a preferred method of delivery for patients with mast cell disorders? Is it better to go with flour only, fewer ingredients, or a product like a gummy that's consistent every time?
That's an interesting and difficult question. In general, for pain management,
We lost Dr. Tishler. Okay.
Like gummies, like flavorings, or more commonly coloring, that we have to be particularly careful with, in the EDS population. And it's interesting because I'm right now working on an educational series for patient service advocates or bud tenders. Has it really done this again?
We can hear you. We just couldn't see you, but we could hear you. Yes.
Good.
We can see you now as well.
So I was saying I was working on this thing for the bud tenders, and it's really important that they have access to and know that they're responsible for having those ingredients available, so that folks, with EDS or a number of other situations, can go in and ask and be assured that they're getting stuff that's safe. In terms of the cannabis itself, I think it doesn't make that much difference, to the mast cell issue. Where we see problems come up most commonly is in folks who have POTS, because cannabis, as you all know, can cause a transient decrease in blood pressure and a compensatory increase in heart rate. And for many folks with EDS, that's not a problem, but it is a concern going into it. And so we have to be very gentle about the dose. I often start people with EDS at even lower doses than I would, the average bear, and really take the time to make sure that those few relatively rare negative occurrences don't happen. And the nice thing is that by starting low and also taking a fair amount of time before advancing the dose, these things can kind of be overcome, because our bodies do adjust over time. And so that even the presence of POTS is not a contraindication, it's just kind of more of a yellow flag, but we can get around this by careful progress.
Thank you. And our last question, I'm actually going to turn to Dr. Hakim. You've got 2 minutes for this one. Could you give us some advice? Yeah, no pressure at all. Could you recommend and give some advice about how to get various providers to communicate with each other, and which practitioner, if there is one, can help manage and oversee everything?
Yeah, no, great question. And I think it perhaps wraps up on all of the various things that this wonderful panelists have been talking about. Personally, I don't think it needs any one particular individual from any one specialty. What it needs is a person who is willing and able to be your advocate. And we talk about this a lot in the Echo Network work that we do. I remind the therapists and the doctors and everybody else that's in the room that all of us can, in one way or another, be an advocate for our patient and build that network, that multidisciplinary team around the individual. Now, I'm very aware that in many respects that's potentially easier for a clinician to do, a doctor to do, because of the potential hierarchy there might be in decision-making or referral-making from doctors versus therapists in different countries and different systems. But it really absolutely starts with one clinician of any specialty being the catalyst and building that network around them. I think somebody asked Tina, how do you find all these different people around you? Well, it's taken me 20 years to find all those different people around us, and we have them now in our network. So the one thing I also say to all of my clinicians is this doesn't happen overnight. You have to build that relationship with all of these experts from the different areas of medicine and healthcare over a period of time, identify them, capture them, bring them in. I've done exactly the same, for example, Fraser, with several people who are superb in their prototherapy treatment in the UK, who I didn't know 3 years ago. And I now have an amazing network of colleagues in pain management who are delivering on various aspects of pain management, including the use of cannabis-based medicines. So it boils down to the patient's relationship with an individual who is able to catalyze that network.
Thank you. Perfect way to sum up. And thank you so much to all of our speakers. A special thank you to Dr. Burling. I think it's 3 o'clock in the morning for you right now in New Zealand? Yeah. So very in the middle of the night. Thank you so much for staying up. And Dr. Wang, Dr. Tishler, appreciate you all, and Dr. Hakim, of course. Thank you. Now go and have a wiggle wherever you are, no matter what time of day it is, or in the middle of the night. You've got 20 minutes to go have a good wiggle, have a tea, have a coffee, or have a glass of wine. See you soon.